Hey everyone, it's Kayla Reams with Dr. Reams Concierge PT, and I am here with Dr. Williams. She is here at CHI Memorial in Chattanooga. We're going to talk about some stuff related to breast surgery and self-exams, mammograms, all of that fun stuff. So thank you for being here with me.
Thank you for having me. I'm super excited to talk to everyone today.
Yeah, so if you want to give just a little background about kind of where you practice, where you got your degree, stuff like that.
Okay, I am originally from Augusta, Georgia. I did my medical school training in Atlanta at Morehouse School of Medicine, and then I went to Johnson City and I got my general surgery residency at ETSU.
Okay.
And then I did a breast fellowship, and when I say fellowship, that means that I am a breast surgical oncologist, so I had special training in only breast.
Yeah.
And that's all I do now. Here in Chattanooga, we have only 3 fellowship trained breast surgeons, and that's myself being one of them.
Yeah.
My partners, Dr. Betsy Washburn, and then Nikki Walker.
Awesome. And so that is very important. While we were kind of discussing this before, really, truly, with any healthcare professional, you want to know what their training is, but finding that fellowship trained, knowing that this is what they do, they've had extra training in, all of that stuff. So Dr. Williams was kind of telling me how to find that information. So do you want to tell everyone?
Yes. So most people, you can just do a Google search. And even if you type in a fellowship trained breast surgeon, it may pull up multiple surgeons. But then if you pick one of those surgeons, you can specifically look up that surgeon. And then it will usually say in whatever you're reading about them, whether or not they have a fellowship training. And that those can happen all across the country, and so we all do our fellowships in different places. But you will usually see that in their background that they have had a fellowship training.
Yeah, fantastic. Thank you. Yeah, same thing goes with like PT and all that. Is there's different trainings for specific things. So if you just kind of look at, they had more training or education, even if the words don't make sense to you.
Yes.
Some of that stuff, and you can ask these doctors and PTs and anyone else what those mean.
Yes.
They're often very proud of it. It's fantastic. It's hard work. So let's start with when to start doing exams. What do those exams look like? Whether it's self-exam, mammograms, and when to stop, if ever.
Okay. So we usually follow the American Society of Breast Surgeons when we talk about when to start screening, how often you should get screening. And so we usually recommend by the age of 25, and a lot of this may not be done by a breast surgeon.
Yeah.
A lot of it may be done by your OB-GYN or your primary care provider.
Okay.
And we say at about 25, everyone should have a formal assessment for breast cancer.
Okay.
Or breast screening, a formal breast screening assessment.
Mm-hmm.
And what that looks at, it may look at your family. A lot of it looks at your family history to kind of tell whether or not you're high or low risk for developing a breast cancer in the future. The statistic that we usually tell all of our patients is that 1 in 12 of us will develop a breast cancer over our lifetime.
Okay.
And as we get older, that risk goes up.
Yeah.
And so for actual breast screening, I usually say, and all of my partners are, they all follow the same guidelines.
Yeah.
We're going to say, hey, starting definitely for average risk women, that you should start screening at the age of 40.
Okay.
And then we say you need to do that on an annual basis or every year until your life expectancy is less than 10 years.
Okay.
And so you can see how that may mean that a 90-year-old still gets their mammograms.
Yeah.
Because we have a lot of healthy 90-year-olds, their parents, maybe their grandparents lived until they were 100
That's my
or
family.
105.
Yeah.
And so if you are still healthy enough to tolerate the treatment that we are going to recommend, we say that you should still be getting mammograms. It is quite different from pap smears. After a certain age, your OB-GYN or your primary care provider may say, hey, you don't have to get pap smears anymore.
Yeah.
But it's not the same for mammograms.
Okay. Excellent.
Okay.
And self-exams.
Definitely.
Yeah.
So, self-exams, I think at any point, even as teenagers, we should all be doing regular self-breast exams.
Okay.
And it's not something that you have to do every day, once a week, but we usually just say once a month, You just have to touch the breast. That can be, there's different ways of doing it. It can be in a circular motion. It can go, in a parallel up and down motion. The whole goal is just to touch the entire breast to make sure that you don't feel anything that's new. And a lot of people will say, hey, I have lumpy, bumpy breasts, which a lot of people do have, and especially younger women, they do have more dense breast tissue. And so it may not feel smooth in every part, and you may kind of feel this cobblestoning. But if you do regular self-breast exams, you will know what's normal for your body. And so when something is not there, the people who have been doing regular self-breast exams, they're more likely to pick up something that they may not have picked up if they're too young to get breast imaging, or if it's not time for their breast imaging.
Yeah. So I have had, I think, like 2 mammograms now, multiple biopsies, and I'm 30, right? And so I've been doing exams, I feel the differences, all of that fun stuff. And so I'm young, but I know my family history and all that, and I don't follow a particular motion. I just make sure I touch all the tissues. So just like she's saying, right, is if you're one of those people that want guidelines, there are guidelines out there, but touch the whole breast, very important. I've treated people young, 19, so please assess.
Yes, definitely.
Yeah. So once we're to the stage of needing surgery, right, what should someone expect kind of leading up to that surgery, that post-op stage, right? And then maybe 2 or 3 years down the road or something like that.
So when we talk about surgery, and probably a lot of the patients that you will see, it's usually in reference to our breast cancer patients. And so when we talk about breast cancer, there's usually 2 major types of surgeries that we're going to do. Well, actually, let me say 4. 2 of those related to the breast and how we're going to treat the cancer in the breast, and the other 2 is related to the lymph nodes and how we're going to treat those lymph nodes. So the smaller, I won't say least invasive, but the smaller of those procedures is what we call a lumpectomy. And what that means is that we're going to take the cancer out with a rim of normal tissue around it to get what we call negative margins. And at the same time, for most people, if you have an invasive cancer, we want to check the lymph nodes. And that is just to see if the cancer has made the first step out of the breast to the lymph nodes. The first place that a breast cancer is going to spread is going to be to the lymph nodes under the arm. And so that is usually called a lumpectomy with a sentinel lymph node biopsy. Our bigger surgery is called a mastectomy, meaning we actually remove the entire breast. Sometimes that means saving the nipple, and sometimes it doesn't. But even with a mastectomy, we still want to check the lymph nodes to make sure that the cancer hasn't spread. If the cancer has spread, the 4th type of surgery that we may end up having to do is what we call an axillary lymph node dissection. And that's, when we talk about the lymph nodes and, kind of how we work together, when we talk about a sentinel lymph node biopsy, the risk of developing lymphedema on average is about 7 to 10%. When we talk about an axillary lymph node dissection, that risk can go up to 40%. Over, and this is over your lifetime. It's not immediately after the surgery. I see people that come back in years after their surgery and they had one small cut, they got on a plane, they had a bee sting, and they developed lymphedema.
Pretty roses.
Yes. Multiple years after their breast surgery. And so, of those surgeries, most people are only going to have sentinel lymph node biopsies. Because we're doing a really good job of catching these cancers early. And so, like I said, most people are going to have the smaller surgery, but it still has a risk. It still is a 7 to 10% chance. And some people who even have the smaller surgery, they do ultimately develop what we call lymphedema or swelling of the upper extremity. And not just can you get swelling of the upper extremity, you can get swelling of the breast.
Kind of that mid-back area. So
when we talk about how to prepare for surgery, for most breast surgeries, there's not a whole bunch of things that you have to do to prepare. But it may actually depend on which type of surgery. So myself and my partners may have their patients do other things. But for myself, when I say, hey, if we're going to do a lumpectomy, I am essentially, remember, I'm going to take the cancer out and I want to get a rim of normal tissue around it. we're not reptiles. We don't regrow parts.
Yeah.
And so if I take that tissue from the breast, what happens is it leaves a hole there. And most people will get what we call a seroma, where our body, your body makes it, it fills that space with a fluid. And it's just fluid the same fluid that's in our bowels. And what happens is it fills that space. So that's why we say for most people who get a lumpectomy, you don't have to see a plastic surgeon. You don't usually have to have any type of reconstruction because you'll get that seroma there. So I tell most of my patients, the best thing that you can do is to get a good supportive bra. And that way you will have that on the day of your surgery and even after your surgery. And I have most of my patients continue to wear their bra for essentially 23 hours out of the day until they see me back post-operatively, which is usually about 2 weeks later.
Now, do you do a compression bra or just one that fits well, like
one?
Victoria's
So
Secret
I
or
don't
whatever?
do, I don't like give them prescriptions to like get a specific compression bra, but it is, I do want them to have any bra, and a lot of people will find that sports bras are better, but I do want a bra that gives them some compression and definitely holds the breast pretty tight. I don't want it to be uncomfortable, but you want to decrease the shifting of the breast, because the more the breasts move, the bigger that cancer is, or the bigger that space is, it has the potential to fill that space with a lot more fluid, which number one can be painful, and then we end up having to stick needles in it to drain it.
Awesome. And then mastectomy, so the bigger surgery.
For the bigger surgery, it depends on whether or not you're going to get reconstruction or not reconstruction. Usually without reconstruction, still not much to do up front. We tell most of our patients until your surgery, do what you normally do. Life doesn't have to change. But our nurse navigators they will give you things for different surgeries. So for a mastectomy, you don't necessarily wear a bra without reconstruction, because you'll have a bra on, but then you don't have anything on the opposite side. And so we will usually give you a binder. Now, one of the bigger differences between having a lumpectomy versus a mastectomy is most mastectomies have drains. Most lumpectomies do not. And so you will have to deal with those drains. So some people will buy, shirts. You can go on the internet and find all of these nice fancy things. Some people just find a big shirt, they cut holes in them, or they put pockets on them, because you are going to have drains. And so you're going to want those drains to fit in some type of pocket. Now, the good thing, here at Mary Ellen Locher, and if you come to one of us, we have our nurse navigators. They'll give you all of these things. They give you a little belt that you can, wrap around your waist to help keep your drains and things in. And so that's probably the bigger thing, is that you're just going to probably want to wear bigger shirts. It's probably, I usually say it's easier to get a button-up shirt or a zip-up shirt. Not something that you get. Remember, I just operated on you. You don't want to, you're not going to want to lift your arms up. And so I usually say get something that you button up, zip up, and maybe something that has pockets on it.
Okay, fantastic. And then that post-operative stage with the lumpectomy versus a mastectomy. So those first, let's say month or two.
Yes. So everybody's a little different when we talk about post-operative, but I would say, we'll talk about averages. I usually say recovery for a lumpectomy is on average about 2 weeks. And I usually have you come back at that 2-week mark. And most people by then say, hey, I feel pretty good. I barely had to take any pain medicine. That's what I hear a lot with a lumpectomy. And they're really asking, like, when can they get back to normal activity? And so for those 2 weeks, though, they can, most people are going to have you stipulation on weight. And so usually for 2 weeks, you can't do any heavy lifting greater than 15 pounds or any high reaching. And that's going to be for both. It's just going to be a little bit longer for a mastectomy. And so for a lumpectomy, like I said, 2 weeks, no heavy lifting, no high reaching, especially if you check the lymph nodes. Because remember, that incision up under your arm is going to affect if you have to reach it for something high. And then, like I said, you'll get pain. Most people will get some form of pain medicine afterwards. You don't really even have to take any, some people ask, well, do I have to be on antibiotics or after surgery? Most people don't have to be on antibiotics after surgery. And so, on average, I would say recovery for a lumpectomy is about 2 weeks. And remember, you don't have to have any drains, so that's always a good thing.
Yes.
However, in that 2 week period, remember we initially talked about, I do have you get a very supportive bra. You're going to wear that until you see us back. And usually at that point, as long as everything is fine, you don't have a big seroma that we need to drain, you know, at that point, that's when we will usually talk about our pathology and, you know, say, hey, did we get negative margins? Do we need to do anything else with the lymph nodes? And then we talk about sending you to our counterparts for what we call adjuvant treatment or treatment after your surgery.
Okay.
And that could be the medical oncologist or the radiation oncologist. And so it just depends on kind of your particular cancer and what all we need to do.
Okay.
For a mastectomy, I usually say recovery time is going to be, instead of just 2 weeks, about 4 to 6 weeks, because it is a bigger surgery. And then when we talk about doing reconstruction, that you're probably going to be on that 4 to 6 week mark versus people who don't get reconstruction. A lot of them may come back in 3 to 4 weeks and say, hey, I feel really good. And even some of them say I barely had to take any pain medicine. So you'd be amazed at how well people tolerate these surgeries. Now, like I said, everybody's pain level is different, but on average, people tolerate these surgeries really well. You're essentially going to do the same things for a mastectomy that you would do for a lumpectomy. It's just a longer period of time.
A little bit more tissue, a bigger scar, all that.
So we'll say instead of just 2 weeks for the heavy lifting and high reaching, we will say, you're probably going to do that for 4 to 6 weeks.
And one thing, you'll hear that number 4 to 6 weeks a lot kind of throughout different things. That's the average healing time for the body. So you'll hear me talk about it with scar management, other stuff as well. It's a common theme.
And especially for us in the field of surgery, like you said, it usually is about, and even at the 6 week mark, your surgical scars aren't completely healed. There's still a lot of process that goes on for months and months. But on average, about 4 to 6 weeks for kind of things to kind of incisions to heal.
And be safe to start moving again and all that stuff. So then the 1 to 2 year mark, just kind of later on, anything they should expect or look out for, anything like that?
I forgot to mention with the mastectomy, I initially said most people will have drains. Usually by that 2 week mark, that's when they're going to get those out. And so, of course, we'll take those out if they're ready to be taken out. That's probably, like I said, one of the bigger differences also in the postoperative period.
Just learning how to manage that.
Now, after surgery, after we figured out whether or not you have to have chemotherapy, after we figured out whether or not you have to have radiation, then we talk about that follow-up period. On average, most people are going to follow up with their breast surgeon every 6 months for at least 3 years. And as long as we haven't had any issues, everything is okay in those first 3 years, then we will back off and we'll say, hey, you've been doing good. We haven't found any abnormalities on your imaging. Your exam looks, seems to be pretty good. So then we'll back off to once a year for at least 2 years. And so you can see how you're going to be followed very closely for at least 5 years after your initial diagnosis. And then depending on where, kind of what facility you're at, you may continue to follow with your breast surgeon for the rest of your life, and still just kind of do that on an annual basis. Some people will, go back to their primary care providers and let them start ordering their mammograms again. And so everybody's a little different.
But continued kind of checking after that 5 year mark is still important, just kind of depending on who you choose to follow up with.
But you still, like I said, even 5 years after, you still have to follow up. You can get your mammograms on a yearly basis. A lot of people do get confused and they think after an initial diagnosis of breast cancer that they have to have mammograms every 6 months. And we found that there's not really any high yield in doing mammograms every 6 months. And so depending on your treatment, you may get a mammogram about 6 months after a certain point in your treatment, but usually you will go back to getting mammograms once a year. So I have, some people, they're a year out and they go to yearly mammograms again. It's not something that you have to have every 6 months.
Now, if someone has a double mastectomy, then the exam looks a little different, but still kind of that same follow-up timeline?
Still same follow-up timeline. It doesn't, no matter what the surgery is, lumpectomy versus mastectomy, is still going to be every 6 months. Now, what changes, like you said, is maybe the clinical exam. If you don't have any breast, we still say, hey, you should still be rubbing across your chest walls,
Okay.
because most people, if they have a recurrence, it's usually going to be along their scar
Okay.
or somewhere that they can see or feel on the skin that's remaining.
Okay.
And so you want to rub across your chest wall, just like if you had a breast there. You're going to
Familiar
rub
with that
across.
tissue?
Yep. You're going to rub across every part. If you feel or see a lesion, redness, something that looks abnormal, then you're going to reach out to us if it's before your appointment.
Okay. So that kind of leads into the next thing is, when should someone look at reaching out to their surgeon, their oncologist, but primarily surgeon, because that's what we're talking about, whether it's day after surgery or 3 years down the line.
Yes.
Because I'm sure you get phone calls all the time of like, it's a little red, what do I do?
Yes.
So let's give some
So
help.
let's talk about kind of in that postoperative period. So in the postoperative period, there's a couple things that you want to look for. Definitely, you shouldn't be having, fevers. You shouldn't have any significant redness of the skin, because that makes us think, do you have an infection? And you have to be careful not to confuse bruising with redness.
Yes.
Because a lot of people will get bruising.
Yes.
But that is different than, that redness that we're talking about that's related to an infection.
And knowing your skin too, so you may not be able to see very well, but I had a mole removed. I'm naturally red. You can tap me and I become red. So I know the redness on my scar is normal for me.
Yes.
Right?
Yes. Because everybody, like you said, people do have different skin types.
Yeah.
And so if there's any concern, I always say, better safe than sorry. It's not going to bother us for you to say, hey, I just wanted to run you by this. A lot of times you may get one of our nurses, you may get someone in the office, and they may run things by us. But it's better safe than sorry.
Okay.
If there's a question, if there's any issue, just call and ask.
Fantastic.
And we'll say, hey, this sounds like something that you need to come in for. Or, hey, I'm going to see you next week. It sounds like it's normal. If it gets worse, then call me back.
Okay, awesome. What about that kind of 2-year mark, so past that acute healing stage?
Yes. One other thing in the acute phase, the third thing that we really look for, besides any fevers, any redness, any opening of your incisions, I would say the fourth thing is swelling.
Okay.
And when I say swelling, we're looking for to see if I said everybody gets a seroma. We don't want that seroma to be really big.
Okay.
Because it can become painful, and especially in a mastectomy, when you just have that skin left, it puts a lot of pressure on that skin, and it can cause what we call flap necrosis. And so we want to catch those things early. So if you have a lot of swelling, if your breast is like double the size that the other one is, or if you had a mastectomy but it looks like you have a breast there, that means maybe your drain isn't functioning, or maybe you're developing a big seroma. Or on the opposite side of that, you can have a hematoma, where a blood vessel is kind of bleeding inside of that cavity or in that mastectomy flap. And those are things that we want to know early, because we want to drain those so that we don't get other postoperative complications from those.
Very good to know.
Yes. Now, when we talk about in the long-term period, like I said, still, your breast is going to change after any breast surgery. And so it's still imperative that you still continue to do those regular breast exams. And initially, again, up front, you're going to say, hey, I don't really know what I'm feeling. It feels different. And especially, it feels different for people who get radiation.
Oh, yeah.
Because not only do you have scar tissue from your surgery, you get all these changes within the breast from the radiation. And so that breast feels a lot different than the breast that didn't have surgery.
Yeah.
And so a lot of times I say, you still, and initially up front, you may do it more often than not, so that you can kind of get familiar with what your new breast feels like. And even people that have had a mastectomy, again, you still have skin there. People who have implants in or get reconstruction afterwards, like I said, most of the time that cancer is going to come back to the skin. So you're going to look at the skin, and even people who have lumpectomies, you're going to look at your incision, you're going to look at your breast, make sure you don't notice any lesions to the skin, any redness, any dark areas that you're concerned about, any raised areas. And then of course we want to know if you feel any lumps or bumps in the breast.
Okay, very good. Those are the questions I had. Do you feel there's anything else the audience should know, or like a resource or website that's good for them to reference?
Yes. So you can always go to CHI Memorial's website, and myself and my partners, we're part of breast care associates, and there's a lot of information on the website that everyone can be
I'll put
referenced
that
to.
link on there.
Yes, but the biggest thing, the take-home points is, usually by the age of 25, we want you to have some type of formal breast assessment.
Okay.
And that is usually done by your primary care provider or your OB-GYN. Mammograms for average, and this is average risk women. At some point, we can talk about high risk women because things change.
Oh yes.
But for
I know
average,
that personally.
yes, for average risk women, we recommend starting mammograms at age 40, and you will continue to do this every year until your life expectancy is less than 10 years. And I cannot stress the importance of self breast exams.
Thank you so much, Dr. Williams. I really appreciate
You're
it.
welcome.
Everyone, I'll put that link for CHI Memorial with their resources and all that on there. You can reach out to me if you have any questions.